Thanks for that nice introduction, Caleb. And yeah, it's been a while. So I've been doing this for a little while. So it's good because, first of all, to give a talk at home. And second of all, because now we can kind of build on stuff we've been doing over the years. And I'll try to initially give you a big picture of things. And I will concentrate on a couple of areas that really, after a lot of the base work, which took over a decade to get somewhere, the things that are really yielding fruit. Here's my disclosures. And so I always like to start with the Gartner Hype Cycle. This is a Wall Street firm that evaluates new technologies, and this is how sort of the way things go. When you have something that's brand new, it starts out as being kind of, yeah, I'm not supposed to do this. It starts out as being completely unknown to this whole level of like, oh my God, this is the greatest thing since sliced bread. But things take a while to get developed, and the more complex they are, the longer it takes to figure stuff out. And so then there's this period of called the trough of disillusionment, which is like, well, what happened, to cell therapy? I thought this was so great. It must not have worked. And then slowly over time, as you start figuring things out and performing studies and acquiring evidence, then you get to a point where the technology becomes more popular and then is widely used. So that pretty much fits. I've put the dates here. We did the first patient in 2001. In 2005, it was all the rage. And then for a while there, cell therapy and gene therapy is hard to figure out. It's a biological treatment. It's not just a molecule. So you can imagine to understand how it works and to be able to apply it. And I'll show you, just figuring out the endpoints of a trial when you don't know what you're going to get makes it really hard. So it's taken a while, but as you'll see, I think we've gotten somewhere. Let me see if I can play this. So this shows you how long. This is in Copacabana, and there was a Discovery Channel special back in the early 2000s. And these are the first two patients actually that got cell therapy in their heart in the world. And there they are jogging on the beach. Now, I guess a little, one of these guys couldn't cross the room without being short of breath. So we really was serendipitous that we had such a good response, because subsequently there were patients that didn't change at all. But for me, this was great because seeing this response, I knew that, this was above and beyond anything that could be expected. So I knew I was okay, this is going to work. I just need to figure out how it's going to work. And so but this is kind of, overhyped at the time, but then you get stuff like this. This is a pleasure to read, this editorial in Nature Biotechnology. The guy calls it, should a cell therapy for heart failure with scant evidence of efficacy continue to be tested in humans? I mean, now, if people don't, give you some issues and are a problem, you're probably not on the right track. So it's good to have some haters and detractors, but it definitely, and some prominent people at the NIH as well, even though we're part of a network for the NIH for 12 years. So, but it's definitely a thing where the fundamental sort of bench scientists want to understand all the mechanisms. And from our perspective, we see something that works, that we have people dying that they don't really understand on a day-to-day basis. And if we can affect their lives and make them better, to tell you the truth, yes, I care how it works, but no, I really don't care how it works. I need to get this into people, and then we'll figure out how things are. And something so complicated, that's kind of the pathway we took. So I kind of decided to dedicate most of my career really to researching heart failure. And in the Stem Cell Center, when we first started this in '98, kind of made the motto to be like, we're going to cure heart failure, which at the time seemed absolutely crazy. But I think at the end of this presentation, you'll see that maybe we're not so crazy. It's the #1 cause of death in the world, and so it's a worthy cause. And by 2030, there'll be 8 million people with heart failure. And here you see the progression. You have an event, usually an MI, although there's different kinds of heart failure, and your ventricle remodels. And thinking that becoming a big ball, it can be more efficient, but nothing can be more deleterious. And then people wind up following this path where they have event after event after event, and wind up dying. So, but this is important to understand the clinical trials because we want to look at the events that they have as an important endpoint, and we got to know when we're going to look at these and how. So when you think about heart failure, and I see some of the fellows here, so this, maladaptive neurohormonal changes, that's kind of what happens in heart failure. The body, all the organs are sensing that output is not good enough and we need to do something to fix it. So for example, your autonomic nervous system decides that we need to constrict some vessels and whip the heart into shape. Well, that doesn't work very well, and so we use beta blockers and so on and so forth. So we use ARBs and ACE inhibitors at the level of the kidneys and MARS at the level of mineralocorticoids and diuretics and Entresto. And so everything that we use in terms of medicine in heart failure is geared towards fixing the maladaptive neurohormonal changes that happen in heart failure. Okay, except maybe transplant and putting an LVAD in, because then now you're pumping blood differently. But this is really the landscape of medical therapy for heart failure. And it's great, we made a lot of progress, but they're missing something that's very important, which is what starts heart failure in the first place, what keeps it going. So we've kind of learned backwards with cell therapy, and I'll look at a specific kind of cell called a mesenchymal cell, how that can affect heart failure in a very different way and be complementary to all the stuff that we use in guided medical therapy. Now, this is a complicated slide. I apologize, but just make a couple of points here. So this is HFrEF, okay? So in HFrEF, we have injury to the myocardium. And this could be ischemia, which is the most common thing, but it could be any kind of cardiomyopathy, essentially. And so this is going to activate immunity. So people normally don't think of heart failure this way. Okay, so it's going to activate innate immunity and acquired immunity. And this is actually the fundamental thing that starts heart failure and keeps it going. And so in the innate immunity category, you're going to see that damage then results in basically non-cellular things that happen. And so we have a bunch of inflammatory cytokines that actually have their own bad effects on the heart. And so you'll see, IL-6, TNF-alpha, alpha-1 beta, all these things that you're used to hearing. And then we have a cellular component of that response. And the star of that is a monocyte. And the monocyte goes into the myocardium and turns into an inflammatory kind of myocyte called an M1. And it's a little more complicated than that, but that's pretty much it. And there's it's more recently understood that there are resident macrophages in the heart. And these resident macrophages are key to what's going on, because here's one thing I'll show you. We give a cell therapy that alters this immunity response, okay? And we see one injection that I do have an effect for 5 years. Well, how's that possible? Well, we're probably having an effect on the cells in the heart, and I think the resident macrophages are one of the key players in that. And then in terms of adaptive immunity, you have a cellular response, which is part of that. You also have involvement of the endothelial cell. This is not just a heart muscle problem, it's also a vascular problem throughout the body, okay? And if you ever have studied atherosclerosis, if you had, you'll know that atherosclerosis is an immune problem, and if you can modulate immunity, you can modulate atherosclerosis. So we'll talk about that in a little bit as well. But that's HFrEF. This is HFpEF. So just to show you that heart failure in all forms, including preserved ejection fraction, here's a group of 4 and 8 studies, 374 patients, describing the characteristics of heart failure associated with elevated IL-6 levels. So you can see all these things over here, basically heart failure features, and you can see that functional capacity, max VO2 and 6-minute walk, track with higher levels of IL-6. So inflammation plays a big role in HFpEF, plays a big role in HFrEF. And we really have no way of treating inflammation until. So this took us a while to get to this sort of cartoon here. It's been a work in progress. And now actually I could go a step further. But anyway, you have these, so I talked about these M1s in the heart. And so these are pro-inflammatory macrophages, and they secrete the IL-6s, the IL-1B, TNF-alpha, all these things that actually have a negative feedback loop in the myocardium. And by the way, IL-6, soluble IL-6 that goes to the liver produces CRP. So later when I show you studies in which we measure CRP, it's an indirect way to measure inflammation that's going on. So here's the MPC. So we inject these cells directly in the myocardium, okay? And so they have receptors for IL-6 for these different inflammatory cytokines. And so that cell, it reads the environment. The receptors get activated and it goes, oh, geez, I'm in the house is on fire here and I need to do stuff. And so that's one reason why we think we need to deliver these cells in the myocardium, because that putting them in that environment then makes them respond in a certain way. And so that's exactly what they do. You get a very actually complex response out of these mesenchymal cells. And essentially, they put out substances like SDF1, VEGF, Ang1, which are very good for the vascular system in the heart. But they also have a role in transforming these inflammatory M1 macrophages into healing kind of macrophage M2s that then secrete different substances that have a very positive effect on the heart and the vasculature. So it took us a while to figure this out, but we now have an understanding of why we need to put these cells in the heart and kind of one of the fundamental things that they do and why the effects last so long. Okay, so this is kind of a map of the world of my last 20 years. And so every box here represents a clinical trial, but this is, mainly heart failure here, okay? So you can see that, we have different routes here. We started back, this study was done in Brazil, and we started with autologous bone marrow cells. It's a really easy product. You stick a needle into the bone marrow, you suck it out, you spin it down, and in 2 hours you have a beautiful, fresh product that's of mononuclear bone marrow cells that includes stem cells. But it's not pure stem cells, it's a mixture of cells. But that's how we started. Because when I started this, I figured out, well, geez, nobody accepts this, so what's the easiest way that we can do it? And so we figured, and autologous is good because it's your own cells, so it's an easy way to do it. And so we followed this study with the first study here in the United States of cell therapy, and then we followed that with an NIH study in cell therapy, all with autologous bone marrow. And this was a relatively weak therapy, but it wasn't completely, you saw those guys running on the beach. And the interesting thing about, I call it focus CTRN, it was a late breaker at ACC in Chicago, and I had 8,000 people in the audience, and I'm the first guy to present this. They just gave Dr. Brunwald a lifetime award, and I go up there in front of all these people to present essentially a negative trial. Why was it negative? Because I picked the wrong endpoints. So if I had picked ejection fraction, I'd be sitting there going like, and when we hit our primary endpoint, we had a significant change in LVEF. But I picked end systolic volume, okay? And that was negative. I mean, so because EF is, the formula is end diastolic volume minus end systolic volume normalized over end diastolic volume. So I missed it, and there's nothing you can do, okay? And I'm basically presenting and getting nailed by this panel of 8, leaders in cardiology. So it was a real pleasure. There have been great moments in this. But so this is this kind of cell. But we've used, for example, I put it yellow because fat-derived cells. And this was a study that I did in Madrid. I actually flew to treat every patient there. It was I got to know Spanish wines really well. And this is a study we did with a different kind of bone marrow cell. And this is a study that we did the first in man mesenchymal cell injection. I did that in Australia. And then we did a phase 2 trial here in the US. And then we did the DREAM-HF, which is a phase 3 trial of mesenchymal cells here in the US. And this is a trial I'm going to show you. And these are kind of the things that we have going on or about to start. And this is kind of like, okay, where have we gotten? Okay, this profile looks very different than this profile because we learn. And you take a step and you go like, oh, okay, and then I learned that, now I'll do this differently. So we're looking at a phase 3 trial that the FDA has already told us, and we've talked to them. It's approved. We just got to repeat what we did here. So I know the recipe. I know the endpoints this time. And the problem is, see this red line I put in here? This red line is because Wonderful Johnson & Johnson felt that they weren't making enough profit from the mapping system that we use. And it's what is like Carto, except that they bought Noga, which is the same thing as Carto, and for the purpose of injecting things into the ventricle. And I was there, okay? This was in Israel. It was developed in Haifa. And they paid $500 million for it. They got Carto along with it, and Carto turned out to be how they ablate AFib. And it was a multi-billion-dollar thing. And Noga, the FDA in its brilliance decided, well, no, we want to make a Noga attached to a therapy. So it'll only get approved when we have a therapy that's approved. Oh, thanks a lot. So now I have to have approved cell therapy or gene therapy to be able to approve this catheter. So J&J, even though this is the gold standard across the world, in the Netherlands, cell therapy is approved for heart failure, and they use this as a, the government pays for it. They took it away. So just as we had the third international meeting here in Houston with all the guys around the world about stem cells, these guys take away our mapping system. So I spent a year and a half down in the animal lab, and we developed a new catheter and mapping system. This one's based on the Abbott system and impedance. And it's actually, it turns out it's a lot of work, but it's better than Noga was. But you can imagine we had a little pause here because we just lost how we deliver cells and genes to the heart. And now the FDA approved this catheter with the gene therapy without us ever doing any human studies, which was unbelievable. And so we've already used it in humans, and it's fine, and we're already approved to go to a second phase. So that's what the red line is. Anyway, I'm going to talk about this trial as well, which is a gene therapy trial. So here's cell and gene therapy, and these are induced pluripotent cells. So this is a company in which we're going to have manufactured cardiomyocytes. So it's basically heart transplant a cell at a time. And circular RNA, which is a different way to deliver gene therapy, which apparently is pretty effective. So gives you a general idea. You can see the timeline that this is my fantasy here. We're getting there. So this is an example of a Noga system. So we map the heart in 3D. It's a real time. We can see the heart. We can then put a catheter that's in there, and we map the area of scar, because if you inject cells in the scar, they're not going to do anything. So I need to stay away from that. We usually circle the scar with cells. And here's the actual Noga map. Every black dot you can see, here's where this guy had an anterior apical infarction, and we're giving all these cells around that infarct. So all many of these studies have been done in this way. This is one of my favorite editorials back from 2012. I wrote with Dr. Wilderson as homage to my mentor. And at this time, you can tell we were figuring out how stem cell therapy was going to work. And I say here, we had just figured out age-related changes. When you give people their own cells, you're giving sick people sick cells. And so to get away from that, we went to autologous therapy. So with autologous therapy, you can give 18-year-old Olympic athlete cells to the 80-year-old heart failure smoker diabetic, okay? But if you give that diabetic and smoker his own cells, you're in deep trouble. We figured that out along the trials. And so you can imagine over the years how we, figured these different things out. So let's talk about these mesenchymal cells. They're called mesenchymal precursor cells, and this was a phase 2 study that we did and led across 5 sites here in the U.S. And we did it every time the FDA would review this. This is the first time we used these kind of cells in people. So 25 million, 75 million, 150 million. And each one was kind of a separate little study. I'm used to small numbers. When I got to this trial where I'm doing 600 patients, I don't even know how to deal with that many people. Let me tell you, it's been interesting. But this was what we almost fell out of our chairs with, is that when we did this trial, and this 60 patients, okay, we see that the group that got 150 million cells, and this is 3 years later, at 36 months, had no events, had no deaths, no Now, we got a little lucky probably, but I mean, no SAEs here, no MACE. And the 25 and the 75 million doses tracked with the controls. So we picked this dose to go into phase 3. So that was very, very helpful. But also the fact that we saw, and we had been seeing this all along, is sort of like, man, it's not very significant, but there's something going on clinically. These people are doing better. And here we're kind of able to show it. So we did something called the DREAM-HF trial, and this is the largest trial in cell therapy at 52 sites across the U.S. and Canada, and multi-center steering committee, the whole shebang, data monitoring committee. Actually, John Rouleau in Montreal was amazing because they let the study go. And I was begging with them at one of our meetings. I said, "Come on, man, let me go a little further." He says, "No, he told me they can't tell you, you're the investigator, but they said you have all the data that you need." It's like, okay, that's kind of code for just shut up and analyze your data. So mesenchymal or MPC, so these are immune selected from the bone marrow. So mesenchymal cells are usually the cells that are glued to the petri dish. If you take a plastic petri dish and you put this autologous bone marrow cells, the ones that are stuck on it are the mesenchymal cells. It's actually called a plastic adherence method. I mean, it's very simple actually, but this is a better way of doing it. So if you use an antibody that can find the cells that are the precursors to the guys that are stuck on the petri dish, now you're getting their parents. And so we're getting an early mesenchymal cell, and we're immune selecting what's called the STRO3 receptor, really selecting for STRO1 positive cells. And that's how we get this product. So you get the 1 in a million cells in the bone marrow. You take that cell and it grows. So stem cells have this property of self-renewal, which is kind of like eternal life, really. And you can have a whole bank. So we treated 600 patients with, because we wanted to diversify, but with 3 patients, we could have treated it with a cell from 1 patient, okay? It's fascinating. But the beauty of doing the autologous thing is it's like a drug, because now you've got the same cells at the same dose for everybody. So it's very uniform. It's like a medicine. And that's a very acceptable sort of a pharmaceutical way of doing it, which is really good. And so there are a lot of preclinical studies done. We are part of some of them using these MPCs. And basically, we found that they were anti-inflammatory and immunomodulatory, okay? And both in models of Adriamycin toxicity in pigs and ischemic model in pigs and in sheep. We used to do sheep downstairs as well. So this is very important. And based on this, actually, the FDA let us put non-ischemic as well as ischemic patients into the DREAM trial. And it turns out that's real important because I'm going to show you the difference between non-ischemics and ischemics. So back in 2006 in Australia, we did the first guy with MPCs. And then I just showed you the dosing results that resulted in us choosing the 150 million dose. So here we go. And here's my people from the Center for Clinical Research. It's been a lot of work over the years. 1,100 people, and we're basically down to 537 patients that got randomized, either to receive the cells by the direct injection I showed you, or be control patients that had a whole, what I call masterpiece theater. So we would take them in there, drug them, and we'd actually took an LV angio. So they get a stick in their groin and an LV angio, you felt the heat. So, and then we just drugged them and sat there, making believe we're following a script, making believe we're injecting cells in them. So the patients had no idea if they were controls or not. And then we had a separation between the team that saw the patients afterwards and the team that did the study. So like, I couldn't be on the cath lab floor on the days we were doing it because I didn't inject the cells. And Dr. Fish and Dr. Cheng did. And so that's basically, and here you can see the distribution, about 60-40 of ischemics versus non-ischemics. So look at this. So this is typical for my life. So this is the primary endpoint, okay? I mean, can you imagine a more negative study in your life, the thing that you've worked 20 years for? Because we didn't have enough money, actually, to do the original trial, which we designed for 1,600 patients. And so we had to kind of rework the primary endpoint. And I had sort of, by luck, picked, regular SAEs for MACE, cardiac MACE. But we figured out that if we use recurrent hospitalizations, we could have less patients in the trial. So we changed. We went to the FDA. I mean, you have no idea. Blind statisticians. It was a whole thing. And we changed the primary endpoint to recurrent heart failure hospitalizations. There you go. Okay. So when I send this to New England, I get it back in 3 days saying, thanks very much, but you missed your primary endpoint. We have nothing to do with it. Thanks for the open-mindedness of it, but yeah, that's how the peer review world works. And that's a different topic. But look at this. This is the whole population, okay? This is MI and stroke. Remember what I said about the vascular system and how when you put these cells into hearts, you get a systemic immunomodulatory effect and how atherosclerosis is an immune process? So we have this immense reduction in heart attack and stroke in these patients. Over 50% reduction. How do you get that? I've actually talked to the people of the company, I have no conflict of interest with them, and said, listen, we should give this as an anti-atherosclerosis therapy, but they insist on heart failure. Anyway, when you look at the patients that had a CRP greater than 2, so remember we talked about inflammation, so a high CRP, look at the difference. So most of the benefit is in the patients that are inflamed. So we're doing something with inflammation and immune modulation to get this kind of result. This is why they told us to stop the study. And ejection fraction. So this is a pleasant surprise. So we had a significant improvement in the whole population for ejection fraction improvement. But again, here's the benefit. There's no, if you're not inflamed, no benefit. The benefit is in the inflamed guys, okay? And also in end-systolic volume in all patients, this kind of hits the crossbar over here. But this was nice to see. And the funny thing is, it doesn't really matter, okay? Because people don't understand, like I told you about the formula for EF. Sometimes your EF can stay the same and you're negative remodeling the heart. You're doing fantastic. But they're like, oh, but your EF didn't go up. Yeah, because you don't understand how you calculate an EF. So EF is what everybody wants to know about, but it's not that important. It's a piece. And it's really developed in the era of inotropic drugs and all that. Anyway, I wrote a paper about that. It's coming out. Dr. Hood is reviewing it. Okay. So here's the DREAM-HF trial then. That was out of order. And, oh, no. Yeah. So then we looked at the trial a little further because this is a lot of data. And it takes a lot of head scratching to figure this out. Okay, so we did. And I figured it out looking at data and data and data and data. And so this is really cool for those that I'm looking at Nikos because he does heart failure. So this is just a control patients, okay? Forget any treatment. This is control. But the same patients that we had IL-6, which is a subgroup that we just did IL-6 on, we had CRP measurements on. So look at your mortality in this trial as a control patient. If you have a CRP greater than 2, that's 30% versus 7 in over 5 years. It's a mean of 3. IL-6, same thing, 30 versus 10%. So this tells you how important, and this is what I started with, inflammation and heart failure is a major problem, and people die because of this. And these guys are all on maximum GDMT. We need a therapy to address the inflammatory aspect of heart failure. So then we looked at the ischemics, okay? So here's 2-point MACE, and here's 3-point MACE, okay? And you can see here that in the effect was primarily in the ischemics versus the non-ischemics. This is significant, this isn't. And in 3-point MACE, it's the same thing, but the differences are smaller. Now, what if we add inflammation and ischemic heart failure? So now I know from this analysis who are the patients that I got the recipe. Who are the patients that are going to benefit from these kind of cells? It's people with ischemic heart failure that have a CRP greater than 2, okay? And here it is. We just skip down to 3-point MACE because this includes cardiac vascular death, okay? That's a 52% reduction. Highly significant. Holy crap. How could... Resynchronization has been approved for much less than this, okay? This is incredible, but because it's cell therapy and we're not kind of ready for all this, you know, we have to jump through a few more hoops. So to summarize that, you can see here, 2-point, 3-point MACE, all patients, ischemics, inflammation, and here's where you get your biggest bang for your buck, ischemia and inflammation. And you can see here the reductions in the 2-point MACE and the 3-point MACE, which includes mortality. So, I rest my case. Now, let's finish up with a little regenerative medicine. This is exciting as hell. Okay, this is really cool. So, the hippo pathway. So, when you're born, your heart grows from being an embryo to being a baby. And when you're born, your heart gets this signaling which tells it stop reproducing cardiomyocytes in number. No more reproduction of cardiomyocytes. So your heart from little baby to adult grows because every cell gets a little bigger, but not because you have more cardiomyocytes. That's why when you have a heart attack, you have a scar, because if you cut your hand, you get a scar and it gets fixed. But with a heart attack, you just, go to heart failure and get in big trouble. So this is an inhibition pathway that we all have. And Dr. Martin, who couldn't make it today, has been working here for over a decade on this stuff. And this originally published in Nature in mice, and then I've worked with him in pigs. And have figured out how to uninhibit the pathway. So YAP, which is what we call this, are 3 short hairpin RNAs that then have an effect on the Salvador pathway. And Salvador is what's kind of responsible for this phosphorylation here that keeps YAP from entering the nucleus. But if you inhibit it, now YAP can get into the nucleus, and guess what? It turns on transcription. What does that mean? Reproduce cardiomyocytes. You start growing cardiomyocytes. It's freaking amazing, okay? So we have a way to signal to the body to start growing heart muscles again. And this is very interesting because, first of all, the promoter is linked to a troponin T. So this will only work if it's linked to troponin. So it has to be in the heart. Okay, so it's safe because it stays in the heart. And this is a big problem that the FDA's had, and it's no problema. And then there's 3 of these short hairpin RNAs that then do that action. Now, another cool thing about this is that as YAP it goes into the nucleus and activates transcription, that kind of starts also a negative feedback loop that then winds up inhibiting the whole system again. So it's sort of self-contained. You give the thing, it lasts for about 2-3 months, and then it shuts down. Not just because of this negative feedback, but also because of, you're getting more myocytes, so your therapy is getting diluted. And also, with a greater number of cells, that also signals YAP to get inhibited. So it's really a brilliant form of therapy, and one that we've shown was very safe in animal studies. So this is from here, and we published this in Translational Science back in 21. So you can see here the change in ejection fraction in the pigs. Very significant, and this is how we dosed it. And you can see the hearts here, big scar, less scar. So remember what I told you about curing heart failure? Hey, it's not that crazy. We're getting there. And so this is the Salvador HF trial. And so this is ongoing here, single site at Texas Heart. And we've treated 3 patients already, we're going to our next dose. So as you can tell, as any first-in-man safety study, there's we can only do 1 a month. FDA looks at it, says, okay, you can keep going. So it's a very slow thing. It's kind of frustrating. It's good for my research people, but we still, it's hard to keep all these patients coming in. EF's less than 40%, and we MRI the hell out of them all over the time. We're really trying to, so this is a truly first-in-man experience, looking at this and seeing if we have an effect on heart failure. And this will be very, very interesting. So, to end, big picture again, you can see we've done a lot of stuff over the years. We're getting ready to do Dream 2. You've seen Dream 1. I have the recipe. I know exactly who to treat, how to design the study. Guess what? It's already designed. And I'm waiting we have to have a different catheter, so we're developing a different catheter that will be used in DREAM 2. And Salvador HF, ongoing. And we're about to start these induced pluripotent stem cell study. This will be a first-in-man study, also done here at Texas Heart. And the circular RNA will also be another first-in-man study done at Texas Heart. These are both approved INDs already at the FDA, so that's really cool. So that's it, and we really mean it when we say the next first. And I'll take any questions.